Hi, thanks for tuning in. Today, we're going to continue our conversation on heart failure, building on the foundation we laid in my previous video titled Heart Failure Part 1. In this discussion, we will dive into the treatment management of heart failure. If you haven't watched the first part, I encourage you to check it out. Kindly subscribe. Let's get started. So, what are the key priorities in the management of heart failure? First, relieve the symptoms. Next, focus on measures to prevent or slow the disease progression. Next, effort should be made to reduce the risk of mortality and provide patient education that addresses lifestyle choices, salt intake, exercise regimen, compliance to medications, blood pressure, and cholesterol control are all useful to consider. In the effective management of heart failure, you would certainly need to classify and determine the functional class using the New York Heart Association classification. An echocardiogram is essential in distinguishing between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Note normal ejection fraction is 50 to 70%. Identifying precipitating factors for decompensation of the heart failure is an important step and must not be disregarded because addressing these underlying factors can actually impact treatment success. So here I have made a list of some potential precipitating factors to look out for. Anemia, including iron deficiency anemia. Has there been a change in the diet, their salt intake? Review their medications, for example. Drugs such as verapamil can reduce the ejection fraction. Is there any interaction between medications that could reduce the ejection fraction? Think of infections, especially respiratory tract infections. Renal disorders and thyroid dysfunctions are among the precipitating factors that can lead to a decompensation. In the management approach to heart failure, we'll put them into two categories: heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. According to the European Society of Cardiology guidelines, first line therapy for heart failure with reduced ejection fraction, which is less than 40%, should involve guideline directed medical therapy, GDMT, which consists of four key groups of agents, right? One, we'll talk about angiotensin receptor neprilysin inhibitor. These are the preferred agents unless they are not available. Then angiotensin converting enzyme inhibitors, ACEs, and angiotensin receptor blockers, ARBs, may also be used. In the list, we also have sodium glucose cotransport 2 inhibitors, SGLT2 inhibitors. Beta blockers also find themselves in there, and a mineralocorticoid receptor antagonist is also there. Now, GDMT, right, guideline directed medical therapy, should be supplemented with diuretics as needed or as necessary. Okay, and beyond these primary agents that I've just mentioned, additional treatment options may be tailored to individual patient needs. This may include hydralazine with nitrates. This has been shown to be effective among the black population. Ivabradine, digoxin, vericiguat, and there are other devices such as automated implantable cardioverter-defibrillator, a biventricular pacemaker, surgery, and palliative care options may all be used. So here we have a summarized management approach to heart failure with preserved ejection fraction, and the European Society of Cardiology guidelines for this type of heart failure recommends the use of diuretics for symptomatic relief of congestion as first line treatment. Additionally, SGLT2 inhibitors are also endorsed as foundational pharmacotherapy, given their benefits in cardiovascular outcomes. Now, for selected cases, the use of angiotensin receptor neprilysin inhibitors and a mineralocorticoid receptor antagonist may also be considered for heart failure with preserved ejection fraction. All right, so now we're going to have a brief discussion on angiotensin converting enzyme inhibitors. You recall from heart failure that renin angiotensin aldosterone system gets activated, meaning that angiotensinogen is mobilized from the liver and it is converted into angiotensin 1 right here, which is done by the help of renin from the kidneys, angiotensin 1 subsequently gets converted into angiotensin 2, this time with the help of the enzyme, angiotensin converting enzyme coming predominantly from the lungs. So when angiotensin 2 binds to the receptor, this leads to a powerful vasoconstriction. It would increase the systemic vascular resistance. You also recall from heart failure that there is a decline in the cardiac output, which means that this will decrease renal perfusion so that this will stimulate aldosterone secretion. So that when aldosterone is released, aldosterone would increase the reabsorption of sodiums from the epithelial sodium channels, and this would increase the sodium water retention, which is not good for the patient with heart failure. So in general, this can jeopardize or worsen. Again, we can see vasopressin is also secreted, and so all these can increase the preload. This can increase afterload. Blood pressure may be elevated, and the ventricular filling pressures may also be elevated, right? And so the medication of interest is this one here, that is ACE inhibitors. And what they do is that they inhibit this enzyme, angiotensin converting enzyme, right here. And when that happens, this leads to another powerful vasodilation. There is going to be a decline or a reduction in the systemic vascular resistance, okay, which is good. And again, ACE inhibitors would inhibit the production of aldosterone, which would lead to a reduction in its reabsorption, leading to a decline now in the sodium water retention. So this would rather help in the sense that the preload would now reduce, afterload reduces, blood pressure can reduce, and the ventricular filling pressures also reduces, which is very good. And ACE inhibitors are also very good for improving cardiac remodeling, which we see in heart failure. Okay, another important thing you should note is that since ACE inhibitors they inhibit the production of aldosterone, this means that there is a predisposition for an increase in potassium, especially if they are combined with a mineralocorticoid receptor antagonist like spironolactone. Okay, so further, I want you to take note of this reaction here as you see that ACE, which is angiotensin converting enzyme, what it does is that it also converts bradykinins into its metabolite. So that if you use these medications, ACE inhibitors, that would rather inhibit this reaction. So that you would rather have more of the bradykinins, which are substances that can lead to this dry cough, which is one of the side effects of taking ACE inhibitors. ACE inhibitors lowers mortality in heart failure. They also lower GFR by dilating the efferent arteriola, and they are considered nephroprotectors because they can reduce proteinuria. And some of the contraindications are bilateral renal artery stenosis, pregnancy, the cough we just spoke about, and ACE inhibitors associated angioedema. So now we are looking at a combination of two agents. We have angiotensin receptor blockers with a neprilysin inhibitor. ARBs share a comparable vasodilating effect with ACE inhibitors, except that ARBs do not influence the conversion of bradykinins, hence they are the right replacement whenever ACE inhibitors causes a cough. They also decrease aldosterone secretion, therefore they can reduce sodium water retention. Okay, in context of heart failure, the combination of ARBs, particularly valsartan with sacubitril, is highly recommended as the first line. Consider a patient with heart failure, say who has a high preload state, high ventricular filling pressures, with signs of congestion. The cardiac tissues under stress or strain would increase or release important peptides known as natriuretic peptides. Examples are BNPs, ANPs, and CNPs. So the importance of these peptides is to promote natriuresis, meaning that this is going to lead to the loss of sodiums, and that will go together with the water. And so there is loss of water that would lead to improvement in the preload. Okay, so neprilysin is the enzyme which breaks or cleaves these natriuretic peptides. In heart failure, these peptides are necessary to promote this natriuresis. So sacubitril is the agent or the drug which is created to inhibit neprilysin. By so doing, we get the positive effect of these natriuretic peptides to promote natriuresis. So sacubitril valsartan is preferred to using AC inhibitors or ARBs alone. Sodium glucose cotransport 2 inhibitors, known as SGLT2 inhibitors. So we are looking at the proximal tubules right there, and this is where majority of the glucose gets reabsorbed. This, in fact, is a cotransporter, meaning that it doesn't only carry the glucose but also carries sodiums. All right. And so if you block these channels with SGLT2 inhibitors, what you have done is that you have decreased the reabsorption of glucose and sodium. And so glucose goes into the urine. It also carries along with it the sodiums. So there is in fact an osmotic effect. And this is beautiful because you are actually getting a diuretic effect from the proximal tubule. Okay, so because of that, you lose volume, they promote natriuresis and diuresis. So there is a decrease in the preload, a decrease in afterload blood pressure. There is a control of glucose independent of insulin. And the unique thing about them is that they decrease sympathetic tone, remodeling, inflammation, as well as the uric acid levels. So, due to these beneficial properties, they are recognized as a cardioprotective agent and are recommended for use in heart failure, irrespective of the ejection fraction or the diabetes status. So, notably, the ability to lower mortality with these agents demonstrates its important role in the management of heart failure. Now, beta blockers, they are very important agents in the management of heart failure with reduced ejection fraction. So let us take a look at what happens in heart failure. There is a reduction in the cardiac output, which leads to a chronic sympathetic nervous system stimulation. This comes with an excessive catecholamine levels that can induce cardiac myotoxicity with time. And these persistent stimulation can also downregulate the beta receptors. So beta blockers reduce the chronic sympathetic stimulation and prevent further harmful catecholamine-induced cardiac myotoxicity. And they are also able to promote the upregulation of these beta receptors. As we mentioned that in heart failure, the receptors are down regulated. Further, we are going to use this medical mnemonic to clarify the other effects of beta blockers in heart failure. So A stands for antiarrhythmic effect. So beta blockers have this property, and it is good because one of the major reasons for mortality in heart failure is arrhythmias. Next is beat and blood pressure. Beta blockers would reduce the heart rate as well as the blood pressure. They enhance ventricular contraction, hence they are able to improve the ejection fraction, and they improve diastolic function and lower the demand for oxygen. It is important to initially address any pulmonary congestion with diuretics before initiating beta blockers in the acute phase. Beta blockers have been shown to reduce or lower mortality, but they require a careful titration starting from lower doses due to potential side effects. Some of the selective beta blockers with evidence include carvedilol, bisoprolol, and metoprolol. Carvedilol itself also has an alpha 1 antagonism, which makes them peripheral vasodilators as well. Some of the contraindications for beta blockers includes a bradycardia, severe peripheral vascular disease, heart blocks such as second or third degree heart block, some obstructive lung disease like severe asthma or COPD may be a contraindication for beta blockers. Mineralocorticoid receptor antagonist. So the activation of the renin-angiotensin-aldosterone system in heart failure triggers the release of aldosterone, which binds to a mineralocorticoid receptor in the cytosol, which actually leads to an increased sodium reabsorption through the epithelial sodium channels. So there is going to be more sodium reabsorption, but this process not only enhances sodium retention, but also creates a negative charge in the lumen. And this negative charge is going to be used to secrete potassiums into the lumen, meaning that if you increase aldosterone, you would probably decrease the potassiums. Okay, so this mechanism is crucial for maintaining electrolyte balance, but excessive sodium reabsorption from aldosterone will certainly pose challenges in the heart failure by exacerbating fluid overload. Okay, so mitigate these effects. A mineralocorticoid receptor antagonist like spironolactone, right here, would compete with aldosterone for this receptor. And so by doing so, it effectively blocks aldosterone's action, meaning that sodium reabsorption will now decrease. And so it will rather predispose to more potassiums staying in the body. So there is more sodium excretion. It is going to spare the potassiums. And one important factors to consider is that it will certainly reduce the fluid overload state. It will reduce the preload as well as the blood pressure and even the harmful cardiac remodeling that occurs in heart failure. It also decreases inflammation and fibrosis. And mineralocorticoid receptor antagonists like spironolactone have demonstrated benefits in lowering hospitalizations and mortality in patients with heart failure who have reduced ejection fraction. Monitoring for hyperkalemia, as I said, is essential, and gynecomastia is also a potential side effect of this agent. Diuretics, particularly loop diuretics, play an important role in the management of congestive heart failure by alleviating fluid overload and providing symptomatic relief for patients with moderate to severe heart failure. So loop diuretics such as furosemide primarily act on the thick ascending loop of Henle that is somewhere here, okay? And they inhibit the sodium potassium chloride co-transporter 2. So we call that NKCC2. This is the co-transporter that diuretics blocks. So once this is blocked, then this will disrupt the reabsorption of sodiums, potassiums, and chlorides. And so as a result, it leads to an increased urine output and a reduced fluid retention in the body. Although they are effective for symptomatic relief, they do not reduce or lower mortality. So this is very important to note. And they are recommended in conjunction with standard, that is congestive heart failure treatment. Other examples may include bumetanide and ethacrenic acid. Torsemide is also another example which offers a longer duration of action compared to furosemide. So when you use diuretics, you must think of gout because it can worsen gout. And diuretics such as the loop diuretics can decrease calciums in contrast to thiazide diuretics, which increases calcium levels. Thiazide diuretics that we see here are a common first-line treatment for hypertension, but in cases of refractory fluid retention or refractory edema, particularly in context of congestive heart failure, a thiazide like metolazone can be added to a loop diuretic to enhance the diuretic efficacy. Standard thiazides are often not effective with a significantly decreased GFR, However, metolazone remains relatively effective under such conditions. Standard thiazides may increase the glucose levels, lipids, urine, uric acids, and the calcium levels. Now let's talk about digoxin. So digoxin inhibits the sodium potassium ATPase, right? If digoxin inhibits this channel, that means that we are not able to get the sodiums out of that channel. So the level of sodiums in the intracellular compartment increases. So how does the cell get rid of the sodiums? It does so this time through the sodium calcium exchanger. Sodiums are going to go out of the cell through that channel, but it is going to be exchanged this time for calciums. So the elevated calcium presence in the cell leads to or enhances the heart's contractility, which is a beneficial inotropic effect. Additionally, digoxin also increases the parasympathetic tone on the heart, which helps slow down the AV conduction. It is particularly beneficial for patients with left ventricular systolic dysfunction who continue to experience symptoms despite standard treatments, as well as for those with atrial fibrillation. However, since digoxin is primarily cleared by the kidneys, careful monitoring is necessary in patients with renal insufficiency to prevent toxicity. While it provides symptomatic relief, it is important to note that digoxin does not improve or lower mortality. And hypokalemia is actually a risk factor for digoxin toxicity, because we can also say that digoxin competes with potassiums. Okay, and so if there is less potassiums, then digoxin toxicity would increase. So here we're going to talk about the mechanism of vericiguat. But first, take a look at this. We see nitric oxide right here, which binds to SGC, which means soluble guanylate cyclase. When nitric oxide binds to SGC, it facilitates the conversion of guanosine triphosphate into cyclic guanosine monophosphate. So it's all about the effect of the cyclic guanosine monophosphate. Okay, so the medication vericiguat enhances the action of nitric oxide's effect on SGC. It kind of potentiates the effect of nitric oxide in that pathway. Okay, so the increase in this substance cGMP promotes vasodilation, alleviates fibrosis and inflammation, and supports reverse remodeling, induces reverse remodeling. And by improving cardiovascular function, vericiguat, right here, also significantly lowers the risk of mortality and hospitalizations in patients with heart failure with reduced ejection fraction less than 45%, specifically in those categorized as the New York Heart Association functional class 2 to 4, and also in those experiencing recent exacerbations of their condition. Hydralazine is a potent arteriolar dilator that enhances cardiac output, and it is particularly beneficial when combined with nitrates, as this combination therapy has shown significant efficacy, especially among Black patients and those who cannot tolerate standard vasodilators. This synergistic effect improves the hemodynamics by reducing preload as well as the afterload. However, clinicians must be mindful of nitrate tolerance and a potential need for a nitrate-free interval to maintain optimal effectiveness, ensuring patients receive the full benefit of this combination. Moreover, if hydralazine has any side effects, it could be a reflex tachycardia, and I think rarely it may also cause a drug-induced lupus. Now, regarding medical devices for systolic dysfunction, in heart failure, mortality frequently stems from arrhythmias, making it very crucial to adopt prophylactic measures when the clinical indicators are present. In short, if you have an ejection fraction of less than 35%, your answer is an automated implantable cardioverter-defibrillator, AICDs. Okay, and if QRS interval is greater than 120 milliseconds, then your answer is a biventricular pace maker. It is very important because they can manage the potential life-threatening arrhythmias and improve cardiac function. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.